all highly welcome to this evening's webinar, which is this month's edition of the YNNF webinar series, which has been on for a while. It promises to be a very interesting session, an educative one as well as usual. And we're honored to have in our midst a very special trainer of ours who will serve as our senior faculty for the day. He'll be introduced shortly by our moderator, who is Dr. Femi Owagbemi, a consultant at the RNC clinics in Lagos.
You are my senior for school. No, this
do kindly mute your mics as you join, and do get ready to participate and contribute and ask questions as you may deem necessary. Do have a very pleasant evening as we go on this journey together. Dr. Owagbemi, over to you, please.
Thank you, Dr. Guga. Good evening, all. I have the privilege of moderating this discussion between our presenters from University of Abuja Teaching Hospital, the audience, and our faculty, Professor Komolafe. The presenters will be discussing pituitary adenomas, and the subtopics are the surgical anatomy and pathophysiology of the adenomas, of the pituitary and the adenomas, and then clinical evaluation and treatment. And they each have 25 minutes to present, after which there will be questions by the audience, which the presenters will answer. And then we'll bring in our faculty, Professor Komolafe, to contribute to the discussion. So the presenters are Doctors Okpanachi and Dr. Oji, or Dr. Okpanachi and Dr. Oji, both residents from University of Abuja Teaching Hospital. And so they can start now.
Good afternoon, the faculty, sir, and other professors present, the consultants, and our fellow residents. This afternoon, the Neurosurgery Division of the University of Abuja Teaching Hospital, Gwagwalada, will be hosting the YNF conference and will be presenting pituitary adenomas. This presentation will be done in two parts. The first part will be about the surgical anatomy, pathophysiology, and classification. I'll be taken by me, by my co-presenter, Dr. Oji, who will be taking on the clinical features, investigations, and then treatments. By way of introduction, the pituitary gland, also called the hypophysis cerebri, signifying its location beneath the brain, is referred to as the master gland by virtue of its control over different endocrine organs. It equally retains this title, master, because its pathology is demonstrated not only in altered physiology of its secreted hormones and the multiple target organs affected, but also with respect to its unique anatomy, especially in relation to contiguous structures. By way of history, pituitary adenomas have come a long way. From prehistoric times, the ancient Egyptians already identified a structure behind the nose, underneath the brain, which controlled growth and other functions of and other endocrine functions. And they realized through the earliest transnasal procedures during modification that treatment of surgery directed at such an organ resulted in resolution of symptoms. However, due to some loss of some documentations, nothing else was found until the late 19th century, where Carton and Paul attempted a temporal approach to the pituitary tumor. And then subsequently, Sir Victor Horsley performed the first transfrontal transtemporal approach to the pituitary gland. We cannot rule out the work of Harvey Cushing, who developed the transsphenoidal approach based on the work by Holster and Schoffer. And Harvey Cushing did an extensive work on the pituitary gland to the point that a lot was named after him: the Cushing syndrome, the Cushing's disease, and even some instruments like the Cushing's perforator were named after him. Fast forward to 1968, where Hardy introduced the concept of microadenectomy, and he also perfected some surgeries on microadenectomy based on the pathologies experienced then. By way of epidemiology, pituitary tumors account for approximately 16% of all primary brain tumors and almost a quarter of the benign fraction. They are the third most common primary intracranial tumor, next to the gliomas, which are the most common, taking into consideration the benign and malignant fraction, and also next in line to the meningiomas. Autopsy and modern imaging studies suggest that 1/5 to 1/4 of the general population harbor pituitary macroadenomas, the so-called occult macroadenomas. Although pituitary tumors occur in all age groups, the incidence is highest between the 4th and 7th decade of life. There is an increasing incidence of pituitary tumors from childhood through young adulthood and also in the elderly population. It's a worldwide in distribution. However, it is said to be slightly commoner among the Blacks, where it accounts for greater than 20% of primary intracranial tumors as against the general population, where it is just about 60% of all primary brain tumors. There's a slightly higher preponderance among the female sex over the males. However, this has been said to be attributed to the fact that most females that present during the premenopausal period, and because of are aware of their fertility and lactation, so they tend to present more. However, from 55 years and above, we tend to get more of males presenting for these pathologies. And there's a general rule that the younger population tend to present more with functional adenomas, while the older generation tends to older population rather tend to present more with non-functional adenomas. By way of embryology, the pituitary gland is a unique endocrine gland in the sense that it has two embryologic origins. It is divided broadly into two parts: the adenohypophysis, which is the anterior portion, and the neurohypophysis, which is the posterior aspect of the gland. It has been theorized that this gland is actually made up of two different organs, different blood supplies, and different anatomies. Rathke was the first to establish the embryology of the pituitary gland, and he established that the neurohypophysis was developed from the diencephalon, the floor of diencephalon, growing posteriorly to meet with the adenohypophysis, which develops from the ectodermal, which develops as an ectodermal invagination of the roof of the stomadeum just in front of the buccopharyngeal membrane. This downward and upward growth, respectively, continues until they meet. And when both epithelium meet, the adenohypophysis now loses its connection with the floor of the mouth, and then with the roof of the mouth, and then that obliterates. If it persists in some certain people, it results in other pathologies that are out of the scope of this conversation for today. Things like Rathke's cyst, cleft cysts. And as Harvey Cushing described it, he says when following the joint embryology, it forms like a ball held in a catcher's mitt.
He's so annoying.
By way of surgical anatomy, we have two images displayed here, the sagittal and the coronal view, to help explain the relations between the pituitary gland and the contiguous structures. In the coronal view, we can see that the pituitary gland itself has its superior relations, the optic chiasma, and then above the third ventricle, and then by the sides, there's the cavernous sinuses, which has its contents both on the floor. The floor, we have the internal carotid arteries lying freely on both sides, the intercavernous aspect of the internal carotid artery, and then the abducent nerve. And then on the wall lies the oculomotor nerve, the trochlear nerve, and then the maxillary and the mandibular divisions of the ophthalmic and the maxillary divisions of the trigeminal nerve. So when the pituitary gland, due to its mass effects, as we shall see later, the compression of any of these structures can result in the clinical features that's found. In the sagittal view, you can see that the pituitary gland itself is related inferiorly to the hypophyseal fossa and the sphenoidal air sinuses. And also, it has its anterior relation to the anterior to the cavernous sinus and posterior to the posterior to cavernous sinus. The paramedian relations have just been described. So if the pituitary gland grows, the growth of the pituitary gland is somehow limited by these structures, the bony structures, and equally the structures that are above. Above here, we have the diaphragmal sella, which is supplied by the second division of the trigeminal nerve, that forms an aperture through which the infundibulum and the portal vessels pass through to meet the hypothalamus. By way of its vasculature, in accordance with its dual embryonic origin, the pituitary gland is fed by two major vascular sources. The adenohypophysis is principally supplied by the superior apophyseal artery, which is a branch of the supraclinoid aspect of the internal carotid artery. This is equally supplied by other arteries such as the primary artery, and also the pituitary capsule itself is supplied by capsular arteries from the carotid siphon. These superior vessels, the neurohypophysis itself is supplied majorly by the inferior hypophyseal artery, which is a branch of the meningohypophyseal trunk. This trunk has a major import in surgical anatomy, particularly with respect to the terminal approach as it guides your when the keyhole is made, it guides the extent to which you should not go beyond. Otherwise, one might injure that meningohypophyseal trunk. These vessels, both the superior and inferior hypophyseal vessels, form a network of capillaries that then drain into the portal system. This network of capillaries is called the glomeruli. By way of histology, on cross section, pituitary gland is made up of several acini of cells that are clustered together that form a unique architecture. These several acini of cells, these several acini of glands themselves are uniquely arranged in such a way that the anterior aspects is the anterolateral aspects has the growth hormones. Posteriorly, we have the somatotrophs, and the central portion usually is where we find the corticotrophs, while the anterior central portion is where we have the thyroid stimulating hormone secreting glands. Various modalities have been put forward to explain the etiology of the pituitary adenomas, which is largely unknown. However, several lack of mutations have been considered causative, and epigenetic alterations have equally been studied. At least on the slide, we have a list of some of the inherited syndromes and some non-inherited germline predisposition syndromes, which could account for this, as we shall see later. This is just a slide to show the secretion of the hormones secreted by the pituitary gland and how it affects variety of organs and varieties of glands in the body. And the pituitary gland itself, it's equally controlled by the releasing hormones from the hypothalamus through a negative feedback mechanism. By way of pathophysiology, there are two prevailing theories that describe pituitary tumorigenesis. One is of primary pituitary origin, which arises from intrinsic abnormalities within the gland itself, or from hypothalamic origin, where the pituitary tumors arise due to continuous stimulation by a hypothalamic hormone or a factor. These tumors arise from a multi-step process that involves dysregulation of cell growth or proliferation. Several recent studies on recent genetic technology, such as the new generations splicing and genomic profiling, has helped to understand the pituitary adenomas clearly better. First of all, the clonal origin of the pituitary adenomas have been found to be established by the fact that most of these glands, by the uptake, the homogeneous uptake of the molecular, the staining technique, and then also the fact that most of the cells within the pituitary, most of the cells within this adenoma usually exhibits the same type of X chromosome inactivation, particularly for those that are passed on in the hereditary fashion. Also, discrete genetic changes have been established, particularly multiple mutations in the MEN1 gene, cyclin-dependent kinase N1B gene, AIP gene, and also the PRKR1 alpha gene, which have been identified in some rare hereditary syndromes, such as the MEN1 syndrome, the familial isolated pituitary adenoma syndrome, the MEN4-like phenotype, and the Carney complex, which is a complex that involves lentiges on the skin and also pituitary tumors. This predisposes the carriers to a broad spectrum of pituitary tumors. Also, epigenetic changes, particularly when they are germline mutations, actually have been found to be associated and causal to the pituitary adenomas. Also, sporadic mutations, such as mutations in some enzymes, the ubiquitinase enzymes, USP8 or USP48, have been found to be associated with the adenocorticotropic hormone secretion. This is because it's said that the epidermal growth factor, its endocytosis, is being inhibited, and this inhibition results in continuous stimulation of the pro-opiomelanocortin gene, which results in the increased synthesis of adenocorticotropic hormone. Equally, when there are recurrent somatic mutations in the G protein alpha subunits found in somatotropic adenomas, it equally results in the growth hormones adenomas, particularly, and this has been found to be consistent in acromegaly and in syndromes involving acromegaly, such as the Markin-Albright syndrome. Like tumors are everywhere, involving the steps of initiation, the initiation, tumor promotion, and malignant conversion, if there is, and also tumor progression. The initiation, in case of is usually formed when there's either an activation of an oncogene function or inactivation of tumor suppressor genes. However, in the case of pituitary adenomas, there's a unifying view which states that it's a multi-step, multifactorial process, which includes both these initiating genetic events, growth factor promotion by extracellular factors such as extracellular matrices proteins, growth factors, and cytokines, and also when there's accumulation of multiple genetic events contributing to further progression of the tumor in terms of invasiveness or recurrences. Activation of oncogene function is usually occurs as a dominant event, and therefore just one single allele alteration results in a change in cellular function, as seen in 40% of pituitary somatotropins. In such tumors, just a point mutation, like said earlier, in the GS alpha gene leads to the defective G protein subunits and GTPase activity. Also, this leads to persistent cyclic AMP concentrations that consequently lead to the excessive growth hormone secretion that bypasses the growth hormone releasing hormone. This also explains why, in the presence of the hypothalamus, which is supposed to be controlling the growth of the adenomas, these adenomas still keep on increasing in size, bypassing the natural control from the hypothalamus. In contrast, tumor suppressor inactivation usually occurs by a recessive process in nature. Therefore, both alleles of the gene have to be affected to influence the cellular events or function. This inactivation may occur through DNA methylation, either point mutation or deletion, any of which will be found in different loci in various tumors. For instance, in MEN1, the affected gene has been localized to chromosome 11, whereas in sporadic forms of the tumor, different areas of chromosome 11, 9, or 13 have been isolated. The role of the hypothalamus and other growth factors in modulating these events is still under investigation. Genomic profiling too has pointed to two distinct classes of pituitary adenomas. This is going beyond both the germline and somatic pattern of predisposition. This classifies these patients with adenomas into two broad groups: those with almost no chromosomal alterations, those are, for instance, those that are enriched for the null cell adenomas, and those marked with widespread genomic disruption, that's those that have the hormone expressing adenomas. However, this association has been found not to be consistent because, for instance, silent corticotroph adenomas and prolactinomas in men both have been found to be of high risk WHO subtypes, express particularly high frequency of genome disruption in small series. Once the tumor has begun to progress and growth takes its course, this growth can expand either through the supracellular compartment or paracellular areas. That is, it grows both longitudinal and in horizontal directions. Within the cella, this growth could erode the flow of the cella and posterior cleaner processes, and equally spread superiorly into the supracellular systems and cause compression of the optic pathway. It equally could further spread, it's equally compressed on the hypothalamus and obstruct the third ventricle, causing hydrocephalus. Equally, lateral growth is into the cavernous sinuses has seen. When there's inferior extension of the tumor through the flow of the pituitary fossa into the sphenoid and its mother sinuses, it could result in CSF rhinorrhea. The localization of microadenomas within the pituitary fossa has been found to correspond somewhat with the original distribution of normal adenohypophyseal cells, as seen in the histology. By way of classification of pituitary tumors, management of pituitary tumors itself has been said is a multidisciplinary approach. Hence, different subspecialties have found the different ways of classifying it. To the endocrinologist or to the clinician, they prefer to classify pituitary adenomas based on its functionality as functional or non-functional tumors. While the radiologist or the neurosurgeon will actually try to classify the pituitary tumors based on its growth pattern, However, the molecular genetics prefer to look at the molecular subtypes and in its subclassification. It's just what we're saying. Yes, pituitary tumors can manifest with endocrinologic abnormalities through endogenous production of tumor or exogenous pituitary thalamic axis through mass effects. Broadly speaking, it could be functional or non-functional. The functional adenoma secrete excessive levels of prolactin, growth hormone, adenocorticotropic hormone, thyroid-stimulating hormone, adenotrophins, and we shall see the effects later. Tumors, however, not associated with a clinical hypersecreted state, including the null cell adenomas, oncocytomas, and various silent adenomas, are collectively designated to be non-functional. By way of pathology classification, the WHO, the World Health Organization, has been revising the tumor, has been revising over time the brain tumors, and based on the 2021 classification, a lot of changes have been adopted. First of all, they took into consideration the expression of transcription factors, notably the PIT1, the TIP, and also the SF1 transcription factors. This is because these transcription factors are the proteins that guide the arrangement and the molecular architecture of these acini into various areas within the pituitary gland. And when these tumors express this transcription, some tumors express or these transcription factors, while some do not express these transcription factors, such as the null cell adenomas, while in some other tumors, there's just patchy expression of the transcription factors, the so-called silent adenomas. Next is the atypical pituitary adenomas, which is a terminology that is no longer being in use. Because this initially took into consideration the atypical structure of the gland, the extensive P53 staining, pleomorphism, the K167 labeling index greater than 3%, and elevated mitosis index. However, it was noted that these features do not correlate with the clinical behavior of these tumors. As a result, the WHO abandoned this terminology of typical pituitary adenomas, and rather, there have been clearly spelled out tumors that have been defined, such as the sparsely granulated somatotroph adenoma, the silent corticotroph adenoma, lysotroph adenoma in men, and the plurihormonal pituitary PIT1 positive adenoma. As a matter of fact, the term pituitary adenoma is no longer being used. The current terminology for pituitary adenoma, for the formerly called pituitary adenoma, is now pituitary neuroendocrine tumors. Pituitary neuroendocrine tumors. Next is the terminology pituitary carcinoma. This brought up a lot of controversy because what was found previously was that there was no much difference between the adenoma cells and the cells that exhibit carcinoma, the cells that exhibit metastatic behavior, beyond the fact that these cells ab initio were already found to have metastatic spread. However, the histology was the same in terms of the ultrastructure or the staining capability and the nature of the cells. So this adenoma, the stem pituitary carcinoma has been abandoned, and now the terminology is now called metastatic pituitary neuroendocrine tumors. This table just gives us the WHO classification of the pituitary tumors in terms of taking into consideration the transcription factors like we already mentioned, and also the hormonal staining, and also cytokeratin. Next is the imaging classification. This imaging classification takes into consideration the size and growth characteristics of the tumors. In the simplest system, based purely on size, pituitary adenomas could be classified as microadenomas, those less than 1 centimeter, macroadenomas goes greater than or equal to 1 centimeter, and then macroadenomas, giant macroadenomas goes greater than 4 centimeters. However, this does not take into consideration the variability in the size, the variability in the extension, or the variability of the growth and pattern of these tumors. As tumors 12 centimeters, tumors greater than that itself could exhibit a unique clinical presentation compared to tumors that are just 4.5 or 5 centimeters. This led to a classification system by Jules Hardy, which was later modified by Wilson, and it's routinely being used for the imaging classification system of pituitary adenomas. In this system, the relation of the pituitary tumor to the cella has been defined by grades 1 to 5. The next slide shows the Hardy-Wilson grading system of the pituitary adenomas. In grade 0 adenomas, usually tumors less than, they are microadenomas less than 1 centimeter, confined with the ultra-aponeurotic confinement of the cella. In grade 1, there is focal bulging, but the floor of the cella is still intact. In grade 2, there's diffuse enlargement of the cella. However, there is no perforation of the cellar floor. In grade 3, there is focal eruption through the anterior cellar surface. In grade 4, there is extensive destruction of the sphenoid sinus is noted, while in grade 5, there is CSF or hematogenous spread noted. The paracellar extension of the tumor the modification was brought up by Wilson to explain how the tumor grows horizontally and how it compresses on these structures.
You need to begin to round up, please.
This is second to the last slide, sir. Thank you, sir. Stage 0 tumors are intracellular. Stage A tumors extend to the supracellular system. Stage B tumors encroach into anterior recesses of the third ventricle, while stage C tumors elevate the floor of the third ventricle, and stage D tumors just extend into the intracranial growth, and then stage E invades the cavernous sinus laterally. Next is the NOSP grading system. The NOSP grading system takes into consideration the relationship of this tumor to the cavernous to the internal carotid artery, particularly the intracavernous and supracavernous aspects of the cavernous artery, of the internal carotid artery, and respect to its encasement or how it invades into that space. This is particularly important, particularly with respect to approaches such as the endoscopic transfemoral approach to these tumors, as poor knowledge or poor localization of this tumor may result in inadvertent injury or entry into this major vessel. And this tumor is graded from grade 0 to grade 4, with grade 3 divided into the supracavernous aspect and then the infracavernous carotid artery segment. Sorry, it's actually based on, there are 3 lines that have been drawn: the medial, the median, and the lateral lines to indicate the extension. So from grade 0, it's medial to the line. Grade 1, it goes medial. It lies in between the medial and the median line. The median line is equally called the intercavernous line. And then grade 2 goes beyond the intercavernous line, but does not exceed the lateral line. And then grade 3, it exceeds the lateral line. 3A above, and then 3B below. While in grade 4, there's complete encasement of the internal carotid artery. Next, I'll give this space now for my co-presenter to continue on the clinical features, the investigations, and the treatment of pituitary neuroendocrine tumors. Thank you.
I will continue from where my colleagues, in view of the previously outlined classification, the clinical features of the patients or persons presenting with pituitary adenoma could be as a result of a functioning adenoma or a non-functioning adenoma. And this presentation could be those who come with in the category of non-functioning adenoma, the asymptomatic and the symptomatic. And the symptomatic could be elective as a result of mass effects, which could be from suprasellar structures, the dura and optic chiasm being compressed, or parasellar structures as the cavernous sinus and its contents, as been previously mentioned, or from direct glandular compression leading to hypopituitarism, or the CSF flow pathway leading to hydrocephalus. They could also come with emergency, in which case they would come with a pituitary apoplexy that would subsequently be discussed. Incidental findings of pituitary mass would be seen in 10 to 12% of patients who have routine MRI done for other causes, and this would have no symptoms prior to the MRI. The symptoms arising from non-functioning pituitary adenoma are due to, one, a compression of the pituitary stalk, which causes decreased availability of those regulatory hormones from the hypothalamus, or a compression of a functioning gland, or as well as involvement of the hypothalamus itself. This mass effect could lead to various presentations, which in history and then in examination will be found in the following order. It could be from visual loss, which could be seen in the image to the right of the screen, varying forms of visual impairment, from a loss of the vision on the temporal fields, giving a bitemporal hemianopsia, or even what is described sometimes as the pie in the sky, a superior temporal quadrantanopia with probably an ipsilateral visual loss. They could come with headache due to the increasing intracranial pressure due to the stretching of the diaphragma sella as a result of suprasellar extension, or from hydrocephalus as a result of compression, as the increasing mass compresses the anterior recess or the floor of the third ventricle, leading to hydrocephalus. They could also grow so much as to invade the cavernous sinus and the content, the cranial nerves 3, 4, as well as V1 and V2, the ophthalmic and maxillary gets compressed, and then the abducens in the floor of the cavernous sinus, leading to the varying forms of ophthalmoplegia, diplopia, Horner syndrome, as well as facial pain. They could have lateral extensions involving the temporal lobe, in which case seizures will be the presentation. They could also now come as an emergency, in which case they will present with a pituitary apoplexy, and this is due to hemorrhage or infarction of the pituitary adenoma. Those patients will come with sudden headache, altered consciousness, visual loss, as well as hormonal insufficiency. Others may present with a functioning adenoma in the forms of prolactinomas, somatotropinomas, corticotropinomas, gonadotropinomas, and thyrotropinomas. 40 to 60% of the functioning adenomas are accounted for by prolactinomas, and they have equal incidence in both male and female, with female, however, having more likelihood to be symptomatic than the male. Features in the female will include features of hypogonadism, and this will include amenorrhea, oligomenorrhea, diminished libido, and eventual infertility. While in the male, they will come with features of gynecomastia and others of hypogonadism, like impotence, diminished libido, and also the eventual infertility. For those who have a growth hormone secreting adenoma as a functional, in childhood, they will have a gigantism, while in the adults, features of acromegaly will be seen. And these are prominent supraorbital ridge, hypertrophy of the sweat glands, as well as cardiomegaly, spade-shaped hands and feet, as well as arthrosis. And this will be their presenting complaint. While those with adrenocorticotrophic hormone-secreting adenomas, which account for 5%, will come with the features of hypercortisolism, as described in Cushing's disease. And this will include red cheek, acne, thinning of their hair, as well as a red stretch marks and easy bruising, and all the other varying features as shown in the image. Those who come with gonadotropin secreting adenomas, even though are rare, usually are often asymptomatic. Their features will be those arising from compression effects, a mass effect of the mass, and it will include oligomenorrhea, amenorrhea, and infertility. While those with thyrotropin secreting adenomas, which are the least common of the functioning adenomas, account for 1% of patients who will have hyperthyroidism, and they could come with also mass effects in their presentation. So their evaluation of patients with pituitary adenoma will begin with first in the clinic, where we do a visual field evaluation. And it could be that they would have presented previously to the ophthalmologist, or will present first to the neurosurgeon, and you do a visual field assessment in the clinic with a confrontation test and a fundoscopy, in which case you would find the loss of vision from commonly the temporal field vision as a result of loss of incident light on the nasal fibers. And this will result in the varying forms of bitemporal hemianopsia. A fundoscopy will show increasing intracranial pressure with papilledema in the fundus of the eye, and the retina blurring. A more visual field assessment could be done in the ophthalmology clinic where they have Goldman or Humphrey perimetry, or the tangent screen color test, in which case they will require the patient compression, as well as other advanced tests like the evoked potentials and the optic coherence tomography. This image just attempts to show the varying forms of visual impairment, from monocular visual loss to bitemporal hemianopsia, as well as the bitemporal homonymous anopsia, as well as binasal homonymous. These varying forms of visual impairment will be seen. Further evaluation will involve biochemical analysis, in which case you want to establish if there is an endocrine diagnosis, and in this case you also want to get the baseline values, and this will require a pituitary profile, hormone profile, testing for prolactin, FSH, LH, growth hormone, ACTH, cortisol, TSH, thyroxine. In some cases, estradiol and testosterone may be included to get those findings. Usually, the values are normal in non-functioning adenomas. However, terms like the stalk effect could be present, where compression or injury to the pituitary stalk will cause impaired release of inhibitory hormones or regulatory hormones from the hypothalamus, the dopamine, serotonin, leading to falsely elevated prolactin and giving the impression like a functional adenoma, or a hook effect, in which case there will be a falsely low prolactin. However, this is due to the overwhelming large molecules of prolactin that impairs the binding antibodies in the radioimmune assay and giving a falsely low prolactin level. All these would account for hypopituitarism in 1/3 of patients. But for those who have prolactin values 5 to 25 are considered normal, but highly variable is the values for prolactin because of so many factors that would occurs in them. And this image which comes up is a representation of what you find. The binding of the antibody assay, which is overwhelmed by the large molecule of prolactin, accounting for the hook effect, is demonstrated in this ELISA antibody antigen testing. Somatotropin secreting adenoma will cause elevation of growth hormone. The basal growth hormone value are usually better assayed by early morning or 2 hours postprandial, or you do a suppressed growth hormone test. However, the dependable and reliable assay for a growth hormone secreting tumor is to do the insulin-like growth factor 1 level, which is a more sensitive parameter for assessing. And this is due to the fact that it binds to carrier protein, and this stabilizes its level, unlike growth hormone, and is also unaffected by stress and exercise, because in them you may find elevated levels of insulin-like growth factor 1, even in the presence of a normal growth hormone, and therefore makes insulin-like growth factor 1 a more reliable assay for somatotropin secreting adenomas. The adrenocorticotropin secreting adenomas are assessed by doing for hypercortisolism and for hypocortisolism. A 24-hour urinary free cortisol level is used to assess for hypercortisolism because it's 100% sensitive and specific, while values above 150 microgram indicate Cushing's disease. The normal is 20 to 90 microgram. For an assessment of hypocortisolism or adrenal insufficiency, an 8 a.m. free cortisol assay is done. Other assays that could be done to assess ACTA secreting adenoma include salivary cortisol, methyl test, as well as inferior petrosal or cavernous sampling, in which case they test for the gradient assay of corticotropin releasing hormone from the hypothalamus, which is given intravenously, and then the values for the gradient of ACTH at the 2nd, 5th, and 30 minutes are assayed, and the ratio is measured for those times to get a value for a secretion of a tumor of the secreting tumors of ACTH. Further evaluation for the patient with pituitary adenoma will involve radiologic evaluation, and the gold standard is usually the magnetic resonance imaging, which is required both for diagnosis and for planning surgery, because it gives a better soft tissue resolution and better tumor delineation with its surrounding structures. 75% would give hypointense signal on T1 and will give a hyperintense signal on T2, whereas the timing, this is usually done using a pituitary protocol that will involve the radiographer generating slides at coronal section that will show the optic and the cavernous sinus at 1 to 2 millimeter slice cuts to be able to visualize a mass effect and compression of this structure. The pituitary adenoma would take up contrast easily in the first 5 minutes, because of the absence of a blood-brain barrier, but subsequently will be seen in the tumor, if the image is delayed to 30 minutes, and those will help show the evidence of compression by an increasing cellular region mass. This image shows coronal sections of an increasing of a large pituitary mass, as well as its supracellular extensions, showing a compression at the level of diaphragma cella, giving it the typical snowman or cottage loaf appearance that is described for a large pituitary mass that have had a supracellular extension. A computed tomography scan would show an isodense mass, in which case it is done to properly delineate the bony architecture in order to plan for surgical intervention, whether it's by the endoscopic endonasal transsphenoidal or by the transcranial approaches. And it will show the expansion of the sella turcica as the mass increases, as well as erosion as the case may be. It will also show evidence, the forms of pneumatization of the sphenoid sinus, whether it is the concal, the precellar, the cellar incomplete or cellar complete types, to be able to plan access through the endonasal endoscopic approach, or for those that will benefit from transcranial as the indications may be. Differential diagnosis for a pituitary adenoma will include structures that will cause mass effects in the supracellular regions, and tumors would include craniopharyngioma, rat case cleft cysts, meningiomas, pituitary stalk or hypothalamic gliomas, or even metastasis to the cellular region. Inflammatory differentials will include an autoimmune hypophysitis, pituitary granulomas, and vascular aneurysms, especially the anterior communicating aneurysm, as well as others like the fistulas. Empty cellular syndrome, whether of primary or secondary post-pituitary surgeries, are other differentials. The management for a patient with pituitary adenoma is multidisciplinary, involving the neurosurgeon, endocrinologist, radiologists, the otorhinolaryngologists, ophthalmologists, and pathologists. And surgery is usually the mainstay of modality for most of these tumors, except for prolactinomas that are very responsive to medical therapy. 95% of them will be removed transsphenoidally and 5% through the cranial approach. The modality options of treatments are surgical, medical, as well as radiotherapy. For medical treatment for functioning pituitary tumors, for the prolactinomas, dopamine agonists like bromocriptine, which binds to both the D1 and D2 receptor, or the selective D2 receptor cabergoline, are options of treatment use, and they are given at the stated dose, 1.25 milligram. Side effects should be noted when giving them, that include nausea and headache, while those who do not will now have to benefit from surgery. And it is important to state that when you have given medical treatment for any of the pituitary functioning tumors for beyond 6 months, it makes the surgical planning even a bit more technical because of the fibrous and increased bleeding that would be noticed. And so once you notice the need for surgical intervention, it is good and important you progress, while radiotherapy comes up when the patients have residual or need to progress to that stage. Growth hormone secreting adenoma surgery is often the first line, but medical therapy could include the use of somatostatin analogs, octreotide and lariatides are examples, or even growth hormone antagonists like pegvisomans. ACTH secreting adenomas usually get surgical intervention or radiotherapy. Options of medical therapy includes ketoconazole as well as mitotin, the aminoglutamide. And for thyroid stimulating hormone secreting adenoma surgery and medical therapy involve the use of octreotide. Nelson syndrome is one presentation found in patients who have had bilateral adrenalectomy for Cushing's disease, and they occur in 1 to 4 years after the surgery, and they come with features of low cortisol level, loss of cortisol, negative feedback, resulting in growth of ACTH tumor. The tumor will present with ACTH level greater than 200 nanogram per ml, and the treatment is often surgical, followed by radiotherapy. The surgical line of treatment is the first choice for the non-functioning tumor, and this will the indication for surgical intervention will include tumors causing symptoms by mass effect, tumors that have caused elevation or compression of the optic chiasm if found incidentally, acute or rapid visual loss, as well as for tissue biopsy for questionable cases. The goal of the surgical treatment is to eliminate the mass effect and then to preserve or restore pituitary and visual function, and to resect enough of the lesion to prevent recurrence and then obtain tissue for histopathologic analysis. Surgical approaches could be transcranial or transsphenoidal. Options in the approaches in this transsphenoidal include sublabial, endonasal, or transethmoidal, and it could be endoscopic or use of microscopic. Indications for those that will benefit from transcranial with those who had a failed transsphenoidal approach, a large tumor with a bone dumbbell shape, paracellular extensions, inaccessible supracellular tumors, as well as those who have other of these, including ectatic intracellular carotid arteries. And the options would be through a subfrontal, a frontotemporal, also called the pterional approach, or a subtemporal approach. And the transsphenoidal, which I will be discussing in this discussion, was first practiced by Hermann Schauffler in 1907, but popularized by Cushing, and is a contemporary procedure of choice. Is an extraarachnoid approach that requires no brain retraction and no external scar is seen in the patient, except for where fats or tensor fascial lateral grafts were harvested for repair of the cellar floor. If not, there will be otherwise no scar. The basic concept of the transsphenoidal approach that the pituitary gland is an extraarachnoid tissue, and the gland is strictly in the midline, but with hazards on either side. And so it's important to recognize and identify a normal tumor. The preoperative preparation for the patient with an adenoma for surgery would involve obtaining an informed consent, correct hormonal imbalance, and give stress dose steroids where the surgery is to hold, because those who have hypothyroidism as well as adrenal insufficiency would have to get those corrected, especially if there is coexistence of both. Then adrenal insufficiency must be corrected before the commencement of thyroid correction in order to avoid adrenal crisis in the intraoperative or postoperative period. Patient is given an oxymetazoline spray the night before surgery, and then ancillary workup investigations like food blocker, electrolyte, clotting profile are done, chest x-ray, echo, and ECG, and the patient fast overnight. Equipment that are needed will include a microscope, a CM, neuronavigator as may be necessary, and endoscopic cuts. And the instruments to be put in place and prepared are the speculum, the ring curette, as well as a long bipolar diatemy. The surgery, the positioning involves a supine with head turned to the right and chest elevated to 10 to 15 degrees. And then there are 3 phases to the surgery: the nasal, the sphenoid, and the sellar phase. This picture shows the access in the diaphragm, a diagrammatic representation of the access using a scope to access the sellar. And it involves going through the nares in the endoscopic approach through one nair, and then identifying the middle turbinate, which is infiltrated with xylocaine, and then fracture, and then a turbinectomy is done, leading you into its posterior end that takes you into the sphenoethmoidal recess, and the corona superiorly and posteriorly to it leads into the ostium of the sphenoid that allows the infiltration and mucosectomy of the floor to access the cellar floor. It is important to note that once it is accessed, the drill or using a chisel, the floor is fractured, and then an up-biting kerosene rongeur is used to create the opening to visualize the dura. And the dura, a egg-shaped dura incision is made to avoid the lateral structures on this side, which is the bulging of the carotid artery. The normal pituitary is usually firm and rubbery, with the anterior pituitary being orange pink and the posterior whitish gray, but the adenomatous is often purplish gray and fibrous. And so with an egg-shaped incision, the Hardy's curette is used to curette the gland from posterior, superior, and then finally laterally. And then with care taken not to tug or pull on any structure or tissue adherent to lateral or posterior structures to avoid injury to the vasculature, as well as tear of the arachnoid bleb that will result in CSF leak. When that the curettage is done sufficiently with the arachnoid bleb descending, it may be necessary for those that have significant extension to have a lumbar drain put in place preoperatively, and installation of 5 mils of saline or air is done to push down the suprasellar extension into the field of surgery to curette and remove as much as is available for curettage. And the floor is then packed with fat. Muscles previously were used, but because of their putrefying effect, they no longer are used. Well, the floor is now packed with surgical fibrilla or fatty tissue or with a fibrin glue and repaired. Post-operative care of this patient will require initial monitoring in the intensive care unit, with vital signs being monitored and early urine output. Post-hormonal assay is done usually on the 2nd to 3rd day. Post-operative Baxter volume and CT scan are also done, and antibiotics given. Fluid monitoring is properly done. Clinical and biochemical status is assessed, and sample sent for histology, and a radiologic surveillance is done. Complications that are attendant to a pituitary adenoma surgery includes those that happen intraoperatively as intraoperative disaster and must be avoided. It includes entry into the carotid artery when the sphenoid septum is erroneously followed to either side, and therefore it must be ensured that it's in the midline that access is done, or inadvertently opening through the clivus, in which case a biopsy of the pons is done, or opening through the floor of the anterior cranial fossa where olfactory nerves becomes damaged, or overzealous curettage with a tear of the arachnoid bleb leading to CSF rhinorrhea. Other complications will include hormonal imbalance, and the most common and notorious is the alteration in antidiuretic hormone, leading to a central or neurogenic diabetes insipidus. This is defined as urine output that is equal to or greater than 250 mils for 2 consecutive hours, or a specific gravity of urine that is less than 1.003, or a urine osmolality that is less than 200 milliosmoles per kg. In this situation, if initial fluid replacement is done for every volume loss, but if increasing volume greater than 500 mils per hour is lost, then an intravenous replacement is done with a antidiuretic hormone analog, vasopressin or desmopressin, has to be commenced in order to minimize correct the excessive fluid loss. Cortisol deficiency is replaced with steroids using dexamethasone and subsequently prednisolone, and then hypopituitarism is monitored. Other complication could be the secondary empty cellar syndrome, post-operative CSF rhinorrhea, hydrocephalus. Infections could have happened, in which case antibiotics is necessary. A nasal septal perforation could be present, which would require the reconstruction, and entry into the cavernous sinus, which is also important not to have such damage. Patients who have had surgical resection may require further treatment with radiotherapy, or those who are not, who have non-surgical amenable tumor to go for radiotherapy, and this includes elderly patients, medically unfit patients, those with significant post-op residual tumor or the growth of the tumor. And the options of the methods of radiotherapy could be the conventional external beam or stereotactic surgery. Complications attendant to radiotherapy include hypopituitarism, brain abscess, deterioration of vision, neuropsychosocial problem, as well as secondary malignancy. The outcome of surgical or radiotherapy intervention would be both visual and endocrine. Patients who present early usually have some visual improvements in their vision following a surgical resection of the tumor, as well as endocrine hormones returns to normal post-operatively. But those who present late may have to have a prolonged hormonal correction, replacement therapy, and visual impairment that will never return to the pre-morbid state. Follow-up of patient with pituitary adenoma will require a post-operative evaluation, often done 4 to 6 weeks. However, it's important to note that it is at 4 to 6 months that imaging done will give the proper representation of the extent of tumor resection. Subsequently, they will now have an annual magnetic resonance imaging or computed tomography scan, and then follow up with the ophthalmologist and endocrinologist for visual and endocrine function. And then patient who presents in emergency with apoplexy.
Please round up.
Often have deterioration that is due to sudden expansion of the mass from hemorrhage, necrosis, or infarction, and is often a life-threatening condition presenting with headache, vomiting, visual loss, or impaired consciousness. And for them, they will need an imaging that will show a hemorrhagic mass, and the treatment is a rapid decompression, usually a surgery within 7 days of presentation. Finally, I want to present our local experience for patients who have had pituitary adenoma between July 2023 and 20.
You need to round off.
Okay, sir. I'm in the last slide.
Last slide.
Had
30
12
seconds.
patients, and 4 were transcranial, and we had 8 by transphenoidal. In conclusion, pituitary adenoma is a common intracranial mass lesion with varying presentation and neurologic sequelae, requiring a good understanding of the anatomy, and a high clinical index of suspicion is required for a prompt diagnosis and urgent neurosurgical intervention. These are references, and thank you for listening.
Well, thank you, Doctors Okpanachi and Orji, for the lucid and informative presentations. So we'll now ask for questions from the audience, and if you just signify by raising up your hand your interest in asking a question, and then we'll call on you. Any question from anyone? It sounds like no one, or it looks like no one has questions. Yes, questions or comments. Questions or comments, not just questions, or comments from the audience are also welcome. And then after that, we'll invite Professor Komolafe. Dr. Adebayo, please go on. Dr. Adebayo.
Oh, thank you, sir. Sorry, I wasn't sure if I heard my name. Wonderful presentations. Sorry, am I being heard?
Sure, go on.
Okay, thank you. Wonderful presentation by the presenters, very succinct and straight to the point. I wasn't sure if it was mentioned because I was in and out of the presentation. Post-operative quality of life after, especially after transphenoidal and endonasal endoscopic endonasal transphenoidal resection of pituitary tumors. Especially it has to do with olfaction after surgery.
I want to know your take about this concept. And also, I'm not sure if you mentioned, if it was mentioned during the course of the presentation, the postoperative diuresis, diabetes insipidus that happens in patients with pituitary surgery or cellular supercellular surgeries. What's your experience, and will you have any management protocols that you can shine light about? Thank you.
Thank you, Dr. Adebayo. Other questions so that we can take all of them, the presenters can take all of them together. Other questions or comments? Dr. Olomo.
Yeah, thank you, moderator. And I want to appreciate the presenters for that beautiful presentations. So I just have a comment. When we're talking about the pie in the sky, it is actually due to compression in the anterior knee of Willebrand. And the patient normally occur in the patient that have a post-fist optic chiasm, and the patient have an ipsilateral visual loss and a contralateral superior temporal chondrotanopsia. I think he didn't put it well. Then the other section of the anatomy, don't forget the capsular artery of Marconnell that supply the capsule of the pituitary. Thank you.
Thank you, Dr. Olomo. Just to the presenters, in answering his question, let me put a little more context. You might need to differentiate between a junctional scotoma and the pie in the sky that can occur without a junctional scotoma, so that all of the answer can be comprehensive enough. Dr. Francis. You need to unmute your device if you're already speaking.
Hello, can you hear me?
Yes, I can hear you now.
Yeah, thank you very much, the presenters, for a very nice and lucid presentation. Yeah, I wasn't sure when you were describing the doing endonasal transsphenoidal resection of the tumor, the sequence of tumor removal. You know, I thought the lateral aspect is removed early, because if you delay, if you remove it late, when the diaphragma cellular descends, the lateral tumors will be stuck and difficult for you to assess. So some people advise that after removing the inferiorly located tumors, you target the lateral angles first before you now go superiorly. But immediately you dislodge the superior tumors, the cellular diaphragma will descend, and the laterally located tumors will be trapped in the angle. So I don't know what's your take on that. Thank you.
Thank you, Dr. Francis. Order of decompression. Any other questions or comments? So now we can quickly go to answer. Dr. Fred.
Thank you for the presentation. Good evening, everyone. Dr. Oji, I was really concerned when you, on the CT scan finding of patient with pituitary macroadenoma, you mentioned that there's intense contrast enhancement. I think you have to clarify that, please. Thank you.
Thank you, Dr. Fred. Any other? Any other questions? Dr. Adebayo, are you raising your hand again? Dr. Lalere, please go on.
Yeah, good evening, Hon. Am I being heard?
Yes.
Good, Mr. Thank you for the presentation. Quite informative. I want to ask, you said from the local experience, you had about 12 patients in which 4 underwent the surgery via an intracranial route, while 4 had TSA. I want to ask, what are the indications for the choice of cranial roots in those 4 as opposed to the transphrenoidal roots? Then why doing the transphrenoidal surgery? What are the signs that we that we alert us that the adenoma, the tumor has been completely removed? Thank you for the presentation.
Thank you, Dr. Lalere. So let's have the presenters respond to those questions.
Thank you for the comments and the questions. They are well noted. Let me begin to respond to them as they were received. The first question was on the post-op quality of life in view of olfaction for those who have transsphenoidal, endoscopic endonasal transsphenoidal. In the nasal phase of the surgery for endoscopic endonasal, it is required that during the subluxation of the nasal septum, as well as the removal of the nasal septal wall, you do not go beyond 2 cm anteriorly when you fracture the nasal septum. This is because it is from that point that the olfactory nerves arise to the cribriform plates in the brain to continue at the olfactory tract. And once that caution is taken, the patient's olfaction are preserved. And I will link it to our experience where we have had no loss of olfaction in almost all of our patients who have had endoscopic transsphenoidal, because we ensured we do not go beyond 2 cm anteriorly in the course of fracture and removal of the nasal septum to access the midline of the floor of the cellar. Our post-op diabetic insipidus and what is done, the patients would begin to make increased urine output, for which values 250 mils per hour for 2 consecutive hours makes a diagnosis of diabetes insipidus. And for children, it is values greater than 3 mils per kg per hour. And once that is identified, the patients are given fluid replacement meal for meal. And that's fluid replacement meal for meal is using this ideal fluid should be a 5% dextrose in half strength normal saline with 20 millimoles of potassium. In our case, we have often used a 5% dextrose saline with 20 millimoles potassium, and we replace volume for volume. And when values are beyond 500 mils per hour, we commence our vasopressin or desmopressin, as the case may be for those who have. And they have done well most often once you are able to do fluid for volume. And most times, some of them may have the triphasic form of diabetes insipidus, in which case they have the initial short duration fluid loss and then a normalization with subsequent prolonged diabetes insipidus. But we have had so many corrections done for them and successfully.
Sorry if I might cut you, by cutting there.
Yes,
you mentioned fluid, the volume of urine that is secreted per hour. Is that the only criteria for diagnosing?
Please don't cut
diabetes
in, Dr. Adebayo.
Oh, okay.
Dr.
Sorry,
Adebayo, please
sir.
don't cut in. He actually he gave the other criteria during the presentation, but allow him to finish his answer, please, and then we can address the. Thank you very much.
Okay, sir.
Thank you.
Thank
yeah,
you,
but he did
Thank
give
you,
the other things during the presentation.
Okay, thank you, sir. For the CT, the MRI image, I don't know, it was breaking. I wasn't sure of what I heard, but I said it
CT,
is
contrast
often
enhancing in CT.
hypointense.
That was it.
Okay, it is enhancing with the gland first, and then because of the absence of a blood-brain barrier. But in the delayed phase, it becomes enhancing with the tumor as well. And I say it becomes iso-intense to hyper-intense in CT image with contrast. I don't know if then indication for those who had transcranial. In our own center, 2 of the patients who had transcranial have had 2 endoscopic endonasal transsphenoidal. And so by the 3rd surgery, we had to do transcranial for both of them, while the other 2 had significant suprasellar and parasellar extension of their tumors. And so we went straight for a transcranial approach in order to resect their tumor. I don't know if there's one
evidence of tumor resection, evidence of completion of tumor resection.
Okay, yes, the question on what do we find as an evidence of tumor resection when the arachnoid bleb falls into the field and bulges. In fact, it makes it even more difficult for you to continue your curettage or your access to either laterally or superiorly to curette and take out tumor. And that is evident that you have resected significant, if not all, of the tumor. Because a further attempt to go in will cause an arachnoid tear leading to a post-operative CSF rhinorrhea. I don't know if
so that ties into Dr. Francis' question about the order of resection, because you appear to have said lateral last when you were presenting.
Okay.
Perhaps that was a mistake, or perhaps we didn't hear you well. Yes.
No, it's not a lateral first, then the superior, the posterior last. Superior. Well, lateral is not last, sorry.
Junctional scotoma.
Yes, junctional scotoma. And pie, the pie in the sky, like Chief had explained, is when the nasal nasal fibers in the knee of Willebrand are compressed by the mass. A junctional scotoma is when there is monocular visual loss with a loss of the superior temporal quadrant of the contralateral side and a monocular visual loss of the ipsilateral side and a superior temporal quadrantanopia of the contralateral side. There's a central scotoma of the ipsilateral side and then a superior temporal quadrantanopsia of the ipsilateral side. And those are the questions, sir. Thank you, sir.
So the context I was just adding to his question was that the pie in the sky can occur without a junctional scotoma. Right?
Yes, sir.
It can be the starting point of the bitemporal hemianopsia before it becomes a full bitemporal, or if there is a compression at the junction of the optic nerve and the chiasm, then that gives a junctional scotoma. So pie in the sky is not equal to just the knee of, if the knee actually exists, or compression of the junction, right? That's just the context I was bringing. But thank you very much for answering the questions, and thank you very much for those that asked questions. Now it's time to invite Professor Komolafe, who is the faculty for today. He's a teacher, well, my teacher specifically. He is also a figure that most of, if not all of us, know in NANS, having been our past president of the academy. And there's a lot to say about his citation. What is most personal to me is that I cut my neurosurgery teeth under his wings. So I probably should not say more than that, knowing my Oga. So I will invite Prof now to join the discussion.
Thank you very much, Dr. Wagbemi, and everyone. It has been an interesting moment and a very educative session. Kudos to the two guys that presented from Abuja. They try to, smuggle as many facts as possible into their presentation within the time limit. And that's very wonderful. Can you hear me?
Yes, we can, sir.
Yes, Prof. We can hear you, Prof.
Okay, that's good. Well, as you know, we cannot totally say everything that is to say, but the important things which they have highlighted, I just made some other few comments. The first is that pituitary tumor, like most other brain tumors we deal with, may not come to us first. And actually, many times, patients are referred to us from ophthalmologists because of visual impairment or visual loss. Sometimes from ENT. In some cases, there are some cases of pituitary tumor that are big, eroding the floor of the cellar, like has been said, that they may present as if they are nasopharyngeal carcinoma or present with CSF leak. So they may first present to ENT and then they refer to us. Sometimes it's the ORT guys that we send them, particularly when they are investigating a couple for infertility. Sometimes the endocrinologists or chemical pathologists. And as you know, it can also occur in children. So you can also get it from the pediatrician. So we should be aware of this because particularly I wish other group of doctors I've mentioned are here because many people don't really think of brain tumor until it is late. The only good thing about pituitary tumor is that it may present early, or people may have a faster awareness because of a loss of vision and also because of the endocrinopathy. So that's the good thing about it. And sometimes it presents late that the patient may come with hydrocephalus, and if care is not taken, patient may even die from it because of the acutness of the hydrocephalus. So that's how we should also take to consideration those differential diagnostics. These are condomas also sometimes done like that. It's easy to, most of the time, it's easy to recognize a pituitary tumor because by the time they come, most of them come late. In effect, the pituitary tumor we have seen the last 2 months, one has lost vision for 40 years, another one for 6 years. I think the last one we operated for 6 years or 4 years. Many of them would have lost vision before they think of even brain tumor. Because many times people are still a bit ignorant about hospital, the doctors, their specialists. Many still go to roadside men when they can't see well, machine glasses. And those that come to the hospital, they visit optometrists who are not doctors. And many times they are just interested in changing glasses until the patient completely lost the vision. So we should be aware of this. But eventually, it's not so difficult to recognize clinically, particularly because of the visual loss and also features of endocrinopathy in those that are functional. But if we, as we know, any brain patient that we are thinking of, the minimum is to do a brain scan. And in this day and age, I think MRI, except if it's trauma or a bony lesion we are suspecting, MRI should be the first to do that will give us an idea of what we are dealing with. So that identification is not a problem. Now the problem will be what to do with it. Like has been said also, most of them will need surgery because by the time we see them, they are already causing problem. But there are some minute of them, very small proportion that may be handled medically. Usually the hyperprolactinemia and occasionally the Cushing syndrome that medically are very responsive to medical agents. So some of them may still need surgery later. So in this, there is need for close collaboration between the neurosurgeon as well as the physician. And that is where the chemical pathologists will also come in because of the adequate monitoring and measurement of these hormones. Diabetes insipidus can be the presenting feature in some of these patients. So don't wait until post-op to look for DI. Many patients, it may be the presenting feature. Some of them will even be misdiagnosed as having diabetes mellitus until maybe investigations are done and they find that they have some diabetes insipidus. Though it's not common, but I've seen quite a few. And sometimes you just admit the patient while you are working up for surgery. The nurse will tell you that the patient is making so much urine, then you know that the patient is already having DI. Some diseases that are not detected pre-op, it may be intra-op that this will be detected. That you just see that the bag was great, and within few minutes, hours, the urine bag is full again. So the treatment for DI may need to start earlier than post-op in case it is diagnosed. If it is diagnosed post-op, you must be careful in the early phase because sometimes there may be over-infusion of IV fluid intra-op, in which the patient is trying to eliminate in the immediate post-op period. So we should be careful of starting desmopressin or whatever. We should first make sure that we are dealing with DI. And you cannot just base your impression on maybe the amount of fluid pushed out by the patient. The amount of fluid pushed out is important. The specific gravity is also very important. That's what we commonly use because the plasma osmolality may be difficult to estimate rapidly. But the urine specific gravity and the color of the urine with the amount are very important to make the diagnosis of DI, and then you can then treat appropriately. But you must be careful that it's not that the patient has excess fluid which the patient is trying to push out. Because I've seen a situation where DI was used prematurely and also a high dose of desmopressin was used. And then the kidneys shut down. And then we have to be praying for urine to form. So we need to be careful about that also. People have asked about post-operative refaction. With transfinoidal or endoscopic is not as common as transcranial. As you know, when you go transcranial, except if you go terional, then you may preserve the refractory nerve. But if you go subfrontal, you are likely going to injure the refractory nerve. And that is why when you are going transcranial, it's advised you go through the one side, particularly the side where there is no vision or where the vision is loose, so that you can preserve the vision on the other side as much as possible. But if you are able, you can still preserve the olfactory now. You dislodge it from the cribriform fossa with your Watson chain, McDonald, and then lay it under the frontal lobe and put Surgicel on top of it and practice to keep it in place. By the time you finish and the vein fall back, it may find its way and then there may be reconnection back. But if you do both sides, patient is likely going to lose fractions. So it's better to always operate to one side. Except the tumor is so big and you have to go to both sides or go to the midline. And as you know, it can be so huge that you may need to go through the corneas or even interhemispheric or combine approaches. Even some, you may need to combine transsphenoidal with transcranial to be able to completely remove the tumor. So, more or less, I think those are some of the comments I have now. In Ife, we are just coming up with reminder approaches. We don't have treatment yet for endoscopic, but we hope to get very soon. So those that are doing it, you extend the practice to other centers by teaching and collaborating and so on. But that's the way the world is going. Minimal access and also faster surgery, short hospital stays. But we must also not forget that some we still need transcranial approaches. So the people in training must be versatile in both approaches because we need them one time or the other. Thank you very much for this opportunity to contribute. And I hope this program will continue. I think it's a very good program, which topical issues should be discussed, not only for exam, but also for good practice. Thank you very much.
Thank you very much, sir.
Thank you, Prof. Thank you very much, Prof.
We thank everybody for attending this meeting, from residents, fellows, and all participants, apart from Professor Komolafe. I'm not sure I have been able to identify any very senior person that we should recognize. But still, we wish to thank all for making this. Dr. Guga is just informing me that you please have to help me. Oh, Dr. Oji, I believe. Okay, I see Dr. Oji is here. Thank you very much for being
I think two of the trainers are here, Dr. Edgar Otopa and then Dr. Yusuf Dawang, the trainers of beautifully presented today.
Okay.
Yeah.
Dr. Dawang and Dr. Edgar, we also appreciate your supporting the presenters. And so we'll just take a few comments from those I have called and any other fellow or consultant who wishes perhaps to address specifically some of the questions that were asked to the presenters by the audience, that they feel that maybe a little more context in the few minutes we have left, that they feel that a little more context will be helpful. So Dr. Zega, Dr. Dawang, Dr. Oji, other consultants here present. We'll just take a few of those so that we can close out the meeting. And we've already spent about an hour and a half.
Yes. Thank you, everybody. Thank you, Dr. Agbemi. Thank you very much. I highly appreciate your coordinating this meeting. And then I'm impressed by the presenters also, for being concise and straight to the point. touching on very important things. Also appreciate the contributions. The questions are in order. I think our teacher, our prof, has done justice to all the matters that have been raised. I mean, I don't think there's any controversy to settle again. So thank you very, very much for this opportunity. I'm grateful. So good evening, everybody.
Thank you, Dr. Dawang.
Thank you, sir.
Thank you, Dr. Wagwemi. Thank you. Fantastic for that. And I want to thank the guys for the job. And I want to thank Prof for that succinct way to cap it up. I couldn't be more grateful. Thank you very much, sir. Gracias.
Thank you, sir.
Thank you, sir.
Dr. Tokwa. Well, so in the absence of any other comments,
Sorry, Doctor. Okay, hello.
Yes, Dr. Jambi.
Okay, please let me just make a comment. First of all, let me thank Prof. Komolape for making time to be around. Today actually is a very busy day, but he has really made out time to join us for this program. I personally appreciate his being around. And then also let me thank the presenters for their very good presentation. Dr. Francis asked a question on the order of mobilization of the adenoma. I actually didn't want to make a comment, but I think it's important I talk about the order to an extent that would make it easy for the residents to understand. Well, most times, because of the direction that the instruments would have to approach the adenoma, you most times would have to start with the posterior mobilization, because that allows the supracellular extension to cave in into your field of surgery so that you could get the tumor out. And you would also want to do the lateral mobilizations last, because you want to keep the internal carotid as far apart as is possible from your field of operation so that you don't injure them. And also, if you mobilize the lateral part of the tumor quick, you may end up trapping the supracellular component, thereby having a very, very gross inadequate resection. So most times people will start with the posterior mobilization and end with the lateral mobilization. Thank you very much.
Thank you, sir.
Thank you, Dr. Jambi, for bringing that clarification, and that speaks to explaining reason or giving rationale for things being done. That helps with understanding and recollection. We've spent 1 hour 34 minutes, or 4 minutes past the time allocated for the meeting, so I would like to shut down, please, and hand over to Dr. Guga to round off the meeting. But I think that discussions can go on further in personal chats. We can also look at some comments in the chat here. And of course, beyond the meeting, we can have discussions in person and at other fora to continue. Thank you very much. It's been a privilege to do this. Dr. Guga.
Yeah, thank you very much, Dr. Wagwemi, for a job excellently done. Special thanks to our presenters who did it. And I think this, the aim of this entire exercise has been achieved, which is educational advancement, as well as serving as a forum for us to share experiences. Obviously, our experiences aren't uniform. So at this level, learning to interface and interact, which is something that we have to carry through our practice. Nobody's an island. And I'm happy that we are happy to interface and to ask questions and to interact with one another. We can only get better with these. Special thanks to the trainers who have equipped these YNNF members with the skill and the capacity to present so wonderfully. We're proud of your presentation, and indeed all the ones that have come before this. And I know we keep getting better as the days go by. We thank especially Professor Komolafe for making our time to be here, despite your tight schedule. Thank you, Prof. We really appreciate your presence and your comments. Every fellow who's been here may not have recognized. Thank you for being here and contributing, and indeed all the associates. Let's make it a date again next month. The topic will be displayed in due course. You have a most pleasant evening. Bye-bye.